Hey everyone, let's talk about TMTJ arthrosis, and I'm going to just talk mainly about the first TMTJ, but of course, start thinking about with our lesser tarsometatarsal joints that, we're just potentially bringing in a little bit more of that sort of intermediate dorsal cutaneous nerve as well. Now, positioning of the patient initially, yeah, I just have them sitting there. Sometimes I'll plantar flex the foot, but usually with the foot sort of sitting out to the side, we're in a pretty good position as we're standing. Basically, I am going to flood that whole first TMTJ area because people, find huge benefit when we are looking at that locally, because a lot of the time there's just large adhesions to the nerves, to the capsule, to the skin, and we want to free up as much of that as possible. But of course, once we've done that, and there may be some aspects of the saphenous nerve in this as well, but we're wanting to then start coming a bit more proximal and, really again, walking up the leg and seeing where are we finding a lot of this pain. Do consider as well whether patients might need a more medial injection, and sometimes it can be a little bit more distal to the joint, that there's still a little bit of sensitivity and pain that's happening there, and so patients will respond to this quite well. Now, when we're looking at this type of a treatment, patients typically will respond immediately, and typically they'll be looking at that high level of relief around that 90 to 100% as soon as they get back on their feet and they're walking out. Very rarely is there a delayed response to the treatment, and so this is a really nice one when people come in and you say, great, we do need to make sure that we're preventing this longer term with our high arched orthoses with the minimal fill, maybe some taping. Yes, let's get our intrinsics, let's get our post-tib strengthening going, but really people do respond quite well to the Lyftogt Prolotherapy. When they're not, we might consider a steroid injection, but definitely I think this is a very nice, reasonably conservative option to look at. Patients do tolerate it quite well, although some of these areas, if sensitized, can have a bit of pain there. Typically those more medial aspects and where we're making those injections on the medial or the true medial aspect of that medial longitudinal arch, be aware of sort of the veins and varicosities in that area, but if you avoid those, it is better tolerated, and if you do hit those, they tend to be the more painful areas as part of this protocol is. But yeah, do make sure you're going very proximal, because this is the type of thing where we do, we are starting to come to the rear foot, and we are wanting to see, a bit more of a proximal up to that lower leg where we're getting a full release and relief from those nerves as they're coming down as well. But otherwise, a really nice protocol. I use it quite commonly, and it's not uncommon for me to come the whole way across if there are multiple tarsometatarsal joints that have a bit of arthritis and arthrosis associated with them. Do start thinking about, okay, well, actually it's the talonavicular joint. It's one of the lesser metatarsal cuneiforms, it could be the calcuboid joint, and start thinking, okay, well, that's where I'm starting to look. Very simple protocol. Put in a few of these different injections into that area is quite a safe way to go. But we'll cover some of these others off in other videos as well. But yeah, I think it's really important that we start to think, okay, I'm starting to see the pattern here. Cheers.